Placental abruption. Placental abruption is premature separation of the placenta from the uterus. This results in tearing of the placental blood vessels and hemorrhaging into the separated space. This can occur before, during, or after labor. If the separation is large enough and life-threatening bleeding occurs, premature delivery, uterine tetany, disseminated intravascular coagulation, and hypovolemic shock can occur. However, if the degree of separation is small with minor hemorrhage, then there may be no clinical signs or symptoms. Etiology. The primary etiology is unknown. However, there are several precipitating factors including 1. Maternal hypertension, chronic, preeclampsia, eclampsia. 2. Prior placental abruption. 3. Maternal cocaine use. 4. Maternal external trauma. 5. Maternal smoking during pregnancy. Presentation. 3rd trimester. Vaginal bleeding, severe abdominal pain, contractions, possible fetal distress. Diagnostic test. Placental abruption can present in a similar fashion to placenta previa. In order to distinguish between the two, a transabdominal ultrasound is done. However, placental abruption still may not be seen on ultrasound. Important point we should know: placenta previa presents with painless vaginal bleeding, while placental abruption presents with painful vaginal bleeding. Types of placental abruption. Concealed blood is within uterine cavity. Serious complications occur with larger abruptions. 1. Disseminated intravascular coagulation. 2. Uterine tetany. 3. Fetal hypoxia. 4. Fetal death. 5. Sheehan syndrome, postpartum hypopituitarism. External blood drains through cervix. Treatment. At least 1,500 milliliters of blood should be transfused in cases of moderate detachment, and 2,500 milliliters in cases classified as severe detachment. The first 500 milliliters are transfused rapidly. Rapid blood transfusion prevents renal shutdown and anuria. Venous blood is examined 2 hourly for evidence of coagulopathy and, if present, this is treated. Urine output is measured 2 hourly. If the fetus is alive, the decision has to be made whether to perform a caesarean section or the artificial rupture of the amniotic membranes. If the latter is chosen, the circulating blood volume must first be restored. The fetal heart is monitored, and if the fetal CTG shows non-reassuring patterns, a caesarean section is performed. However, it is imperative that first the mother is adequately resuscitated. If there are ominous CTG abnormalities, the long-term prognosis for the baby is poor. Take a look at next table showing comparison of the clinical picture in the various grades of accidental hemorrhage and the severity of bleeding. Indications for caesarean delivery are uncontrollable maternal hemorrhage, rapidly expanding concealed hemorrhage, fetal distress, rapid placental separation. Vaginal deliveries are indicated if placental separation is limited, fetal heart tracing is assuring, separation is extensive, and fetus is dead. Please follow us on Insta Medical Mindset 90.